So let's get started. Hello, everyone. I'm Vivian Mashahwar, and I'm very pleased to welcome you to this month's Smart Talks, which will be presented by Dr. Adalberta or Beto and Loyola Sanchez and his graduate student, Rija Kamran. If you're joining us for the first time, Smart Talks is the monthly seminar series of the Smart Network at the University of Alberta. And as many of you may already know, SMART stands for Sensory Motor Adaptive Rehabilitation Technology. We are a network of more than 300 professors and learners who have come together from many different disciplines to develop interventions that would improve quality of care and health outcomes, especially for persons experiencing neurological conditions. And I am delighted to introduce our speakers today, Dr. Loyola Sanchez and Ms. Kamran. Dr. Loyola Sanchez is an assistant professor in the Department of Medicine, Division of Physical Medicine and Rehabilitation. He is also a practicing physiatrist at the Glenrose Rehabilitation Hospital with focus on spinal cord injury. To give you a bit about Dr. Loyola Sanchez's background, he completed his medical and specialty training in Mexico City and his research training at McMaster University, where he obtained both an MSc and a PhD and was a Vanier Scholar. He also did his postdoctoral training at the University of Calgary, where he was a Banting Scholar. Since then, he has been working on developing a program of research to design, implement, and evaluate community-based rehabilitation programs for people living with disabilities caused by chronic illnesses in outreach communities. This program has mainly focused on underserved populations, especially indigenous and rural communities, both in Mexico and in Canada. He, together with Dr. Chester Ho, is currently leading a CIHR-funded project to create a model to improve transitions in care for people with spinal cord injury in Alberta through a community-based participatory research strategy. Dr. Loyola Sanchez is also the new principal investigator for the Rick Hansen Spinal Cord Injury Registry and one of the leaders for the Alberta Spinal Cord Injury Community of Interactive Learning Series, or Alberta Skills, which is a community-based initiative aimed at empowering people living with spinal cord injury, their family members, and people in their world that they interact with to help them improve the quality of life and enable full integration of individuals with spinal cord injury back into the community. The co-presenter today is Rija Kamran. Rija is a graduate student in Rehabilitation Sciences and is working with Dr. Loyola Sanchez on the CONCENTRIC project, which they will be presenting today. She holds a physical therapy degree from Pakistan, and she aspires to work as a clinical researcher in the future. And we're very excited to have Beto and Rija with us today. Now, just before we hand over the floor to them, a few housekeeping notes. This session is recorded. I encourage everyone to participate in the question and answer session. Please write your questions in chat, marked to everyone, and I will read your questions at the end of the session. Please make sure that you mute yourself during the talk, and to preserve bandwidth, it would be great if you turn off your cameras as well during the talk. And with that, I hand it over to you, Beto and Rija.
Thank you very much, Vivian, and thank you everyone for being here and listening to us. And of course, thank you, Rija, for accepting presenting along with me here. So that's great. So let me just start sharing my screen. Okay, can you see it?
Yes.
Yeah, everything okay? Good. So I'm going to click start from the beginning. Perfect. So so today what we want to present it's mainly the results of one of the stages of a large project that we are participating in that Vivian already mentioned. So the title of the presentation is How to Promote Successful Transitions in Care for People with Spinal Cord Injury Living in Rural Areas, and this will be a qualitative study. So let me see how it goes. Yeah, like this. So we have two main objectives today. One is to present the results from a qualitative study that has been conducted as a part of the CONCENTRIC project. So what is CONCENTRIC? CONCENTRIC is the acronym for Connecting and Coordinating an Enhanced Network for Transitions in Care for people with spinal cord injury in Alberta. This is, as Vivian mentioned, is a CIHR funded project, but with a lot of collaboration from a lot of organizations in this province and outside of the province. Now, what we want to do here in this specific qualitative study was to explain how the transitions from inpatient rehab to the community for people with spinal cord injury in rural areas of Alberta can be improved. And on parallel to this objective, we also want to demonstrate and have reflections with you guys about the value of qualitative research for rehab sciences. And we opted up to do this because we feel that even though qualitative research is well accepted in a lot of other areas in health, in rehab, we are still kind of in the process of accepting and say, well, what is that and how can that help us? So that we wanted to take the opportunity to represent the results, but also to embed or intertwine some reflections about the use of qualitative research. So for that, we're going to have more like a dialogic presentation. So Rija and myself will be sharing the slides, and we'll have this as a conversation between both of us. And hopefully we will have some time at the end to get some feedback and some impressions about these two main objectives. So let's move on and let's begin with the objectives. So first of all, why concentric? Well, why concentric? Well, because there are three main things that are happening in terms of spinal cord injury care in our province. First is we know that there are gaps in the transitions in care between hospitals, primary care, and community, and those gaps means what does that mean? What do I mean by transitions? Well, what I mean is that when a person goes and receives care, for example, in a hospital, and then moves out to the community and then comes back to the hospital for something specifically, those moments are called transitions. And what we have seen is that in Alberta, when people go through those transitions, there are a lot of issues going on. For example, people in other hospitals or in other levels of care, they do not understand what spinal cord injury is. They do not understand what are the specific needs for these people. Also, the second one is that there are a lot of inequities to access specialty care for people living in rural areas specifically. So that is well documented in our province. And all of these results on the third point, which is a high healthcare utilization in regional or rural areas, which is increasing the costs for the health system for our province. So that is the why we are doing concentric. So how are we doing concentric? Well, concentric has three main stages. So stage number one is what we call a situational analysis. Before we got in and tried to solve the issue of transitions, we wanted to know specifically what are those gaps. We knew that there were gaps, but we haven't identified them systematically and scientifically yet. So that's what we implemented, this situational analysis, which is a qualitative study that, and our presentation is going to focus on this. But then once we have these results, now we're currently on stage 2, in which we're using part of these results that we're presenting today and working collaboratively with a big group of people representing different areas and organizations in this province, so we can do something about it. So that means that we can design a model so we can improve the transitions in care. And then in stage 3, we will implement this. That will happen hopefully by the middle or the end of next year. We will implement whatever we design, and then we'll evaluate the value of this. So then we can learn, and hopefully we can move on the agenda of this. Now, it's important for me to tell you also another detail is that we're not focusing in all of the province. We're just focusing on 2 main sites. One is the Slave Lake area. The other one is the lead-rich areas. So these two main geographical locations, we picked them because there were some opportunities of collaboration pre-existing, also because we felt that these two contexts are different enough to give us more understanding of how can we implement something like this in the different aspects of the province and the healthcare system in the province. So today, what we're going to do, we're going to focus on the results, partly on the results of this situational analysis, which was a qualitative study. Okay, so Rija.
So the research questions we used to address our objectives were, what are the experiences of people with spinal cord injuries when they transition from inpatient rehabilitation to communities in Slave Lake and Lethbridge areas? And what are the experiences of care providers seeing people with spinal cord injury in metropolitan and rural areas and how these transitions go? And also, what are the barriers and enablers for these transitions?
So as you can see in these questions, let's make a pause and let's make a reflection. So in terms of the use of qualitative research, as you can see, the whole project or the whole project itself, because Concentric, as I told you, stage 1 fits on stage 2 and so on. But specifically, the project that we're going to present today, which is qualitative, is based on understanding experiences. So ask yourselves the question, can you actually understand experiences by using a black and white approach of that, a cut and clear white, black and white approach of quantifying experiences? Do you think that by quantifying experiences with numbers, we will have a deep understanding of those? Ask yourself those questions. And the thing is that we believe that it's difficult to do that. Of course, it can be done, but it's difficult. And that's when the qualitative research helps us, because qualitative research is it's actually designed to do a scientific approach to understand perspective. So because it tolerates these shades of gray, as we know in our positivist view of science, which is more what we do in our quantitative research, we do not tolerate a lot of these kind of shades of gray in the results. So that's why qualitative research, it's a very good approach to tackle these questions that Rija just mentioned. And also because we are assuming that realities are multiple, relative, and subject to redefinition. Another thing that is not possible to do with the quantitativist or the quantitative research approach to things.
To address the questions, we used an ethnography design, and the data was collected using semi-structured interviews via Zoom. And we used purposive sampling, and the purpose for using that was to have diversity and representation in the narratives that we were collecting. We interviewed people with spinal cord injury living in Slave Lake and Lethbridge, family members, care providers at specialized centers in Edmonton and Calgary, and care providers at Slave Lake and Lethbridge.
So let's do another reflection of qualitative research here. So as you can see, in terms of using these two methods within qualitative research, one is semi-structured interviews, the other one is purposive sampling. In this case, the semi-structured interview allowed us to get in-depth understanding of social worlds through people's circumstances, experiences, perspectives, and stories. Again, something that you cannot get in depth by quantifying. So the other thing is not possible to quantify the meaning people attach to experiences. You can put a number about, yes, I feel good, bad, or it's a great or a terrible experience by a number, but you cannot actually get the meaning in terms of the complexity of that. And that's an important value. So what is a semi-structured interview? A semi-structured interview is that you have a guide. That means that you know what you're going to ask the person to talk about. We don't want to just say, okay, just tell me whatever you want. No, we want to know a specific aspect of your life, but we want you to tell us that story in your own words. We don't want to create close-ended questions that you can answer by a yes or a no. So that's what is important in this case, to reflect on the value. Sometimes we want to measure things by numbers or quantities, but sometimes we want to measure it by the quality, which is the in-depth and richness of stories. And the other piece is the purposive sampling. And in this case, the difference, as we know, in the quantitative, we want representativeness, right? So the sample represents a whole population, which I'm interested in. In qualitative, we don't care about that. We care about how varied are the voices in the project that we are defining. So that means we want to do generalizations, but those generalizations are within the confines of our project. We don't want to generalize to other people. What we want is to get common experiences from the people that we interview. So that's why it's very important to have a purpose when we sample. And that way we can say, I want to have different perspectives. I want man, and I want women, and I want other like gender fluid accounts, or I want different levels of injury, or I want different professions, etc., etc. So you see, that's why the qualitative method helps you to be flexible in terms of who do you include.
As for the analysis, initially, the accounts for people with the interviews that we collected from the people with spinal cord injuries were grouped under what we call the pilgrimages. And pilgrimages is journey of the people with spinal cord injuries, starting from the point of injury until their integration into a meaningful life. As for the purpose of this project, we just focused on the stages from inpatient rehab to community, and fully acknowledging that there are stages that go on before and after inpatient rehab and after their integration into community. And we use the Anderson model for health utilization to identify the needs and enablers from the interviews of people with spinal cord injuries. After that, we did a comparative analysis of these narratives that came from people with spinal cord injuries with the narratives that came from service providers and other individuals of the healthcare team. And we look for agreements and disagreements within them. And after that, we group them under final themes that represented what is necessary for successful transition in care for people with spinal cord injuries from inpatient to community. And after that, we did member checking process. Member checking is a process used in qualitative research to ensure the validity and credibility of our data. So we went back to our participants and we asked if the broad themes that we have come up with are representative of their ideas and their narratives and the interviews that they gave in the first place.
So as you can see, when in a qualitative research and this analytic approach, there is nothing that resembles opinions. Some people say, well, that means that this is research about opinions. This is not science, it's just opinions. No, the reason why we can tell you no, it's because we have a method. As you see, we have clear steps. Of course, Rija summarized them, but each of those big bubbles that you see in there, ingrained in a machine, they have multiple steps within them, but we have steps that are reproducible and transparent. So if someone wants to reproduce the results with a similar study, they should be able to achieve some of the same results and conclusions. So the important things that we need to reflect on this is that these types of analysis are more inductive than deductive. As you know, when you talk about deductive, is I already have a question, I already have a hypothesis, and I want to see if it stands or not with reality. So that's what we are used to doing in quantitative research. In qualitative research, you can do that. But in our case, in this case that we're presenting to you, we are more in the inductive, which means that we are just asking questions about the phenomenon of interest, which is the transitions and their journeys. But it's the people and there's people's stories who become the data that we utilize to understand and frame what is going on, that understanding and that knowledge. So that is what we mean by inductive. And also it's more interpretive rather than predictive. Again, qualitative research is very difficult to use qualitative research to predict a phenomenon, because again, I told you about the generalization thing. You cannot generalize, you need to keep it in bounds of your own research field, or in this case, the research topic, but you interpret. And that, my friends, is really, really hard. So what do we do when I have to run an ANOVA test, what do? I just put my code into my STATA program, and voila, in 2 seconds, I have the results. In qualitative research, there is no such thing. There is no machine that can help us to bring and do these interpretations of the meanings together. So that's when we need to use our own heads. It's really, really hard to do, but it's at the end of the day, it's a very fulfilling experience. But that's the kind of the equivalent with the quantitative world.
As per the results, these are the demographics representing participants with spinal cord injuries. We had an equal representation of male and females. And as per the age, we had a wide range starting from 20 to 75 years. We had Indigenous and non-Indigenous representation. As per the duration post-injury, we had people starting from less than 5 years of injury to over 20 years post-injury. And our population was mainly comprised of people with paraplegia, but we did have some tetraplegic representation. For the type of injury, most of them were traumatic, and injuries were caused mostly by car accidents or resulting from health conditions, closely followed by work-related accidents, fall or being hit by a tree, and accidents from recreational activities. As for the locations, specifically for the participant population, we had a greater representation from the rural and remote areas from both our south and north zones. These are the demographics for participants who were service providers. Again, here we had a variety of stakeholders, starting from healthcare administrators, allied health professionals, family, nurses, physicians, social workers, and community organizations. And for the representation from the south and north zones, we have had an almost equivalent representation from both urban and rural areas from the south and north zones.
So what are the results in terms of the themes, those final themes that represent successful transition? So we found, so far we have found 6 themes, and we will go through them one by one. But our star research coordinator, Lei, I don't know if he's here, but he's such a great asset in this program. He created this acronym that is called MAX Access, which makes so much sense, right? We're talking about access, we're talking about transitions. So it reflects these 6 themes. One is managing healing expectations. The other one is access to appropriate services, client-centered care, continuity of care, education, and social support. So these themes are explaining us what is needed for achieving this goal here, which is success with the transitions in care and ultimately integration to a meaningful life for people with spinal cord injury. And who are going to be the responsibles to make this happen? Of course, people with SEI and what we call SEI stakeholders. So I apologize. I think for some reason it got deformatted, so the format didn't work. Okay, so we're going to start by checking one-on-one. Okay. So the first one is managing healing expectations. So in a nutshell, the results are telling us loud and clear that there needs to be a balance of the known and the unknown regarding physical, psychological, and mental healing for people with SEI. And hope is the main mediator for everything.
And a physiotherapist reported to us that we are not really going to work much on your legs. We are not going to get you and try to walk because it's not going to happen. After saying this, the patients just really shut down and don't listen to us. We need to give them something that they want so they can maintain some hope in their life.
This is a good example of how what we're representing about this balance. There is a huge tension between people, that the perceptions and the expectations of people with SEI and the expectations from the health providers. So this has been an important thing. So managing those in a good and transparent way is very, very important. Now let's move to the second, which is access to appropriate services. So no surprise on these ones, right? There is a need for care, a need of care, financial and community services. So lots of services are still not well integrated, so they are not widely available for people. Even though they could exist, they are not actually doing what they are supposed to be doing. And especially because most of these services do not consider the specific situation of a spinal cord injury.
And again, these are some representative quotes. So a participant with spinal cord injury mentioned that I was too afraid to do anything by myself after making all useless appointments because I had to try and figure it out myself. I do find challenges daily. And a primary care provider said that I think most facilities have limited space for parking, and especially if it comes to wheelchair parking. So that adds a bit of a challenge, especially getting through the snow.
Let's move to the next one, which is the client-centered care. So for this one, what we found is that there is a specific need to involve people with spinal cord injury in the decision-making process, including a very clear communication with their teams to define inpatient and community rehab plans. And this, of course, will allow for individualization. So even though we're aiming for standardization as health providers, people with lived experience, they also want to bring their individuality. And at the end of the day, going through these tensions, remember we said this is all based on analyzing these agreements and disagreements of the stories. We kind of concluded that, yeah, putting the person in the center is going to be the only solution to actually make everything else happen. And how to do that? Well, at least we have a clue here, is that they need to be part of the decision-making process all throughout this.
And an occupational therapist said in this regard that I think communication is probably the best and the biggest one that makes it good or bad memorable, or positive or negative memorable.
So now let's move to the next one on the acronym of MAX Access, which is continuity of care. So there is a clear, the narratives clearly tell us that we need to have clear pathways that ensure the efficient communication and collaboration among all levels of care with the person with spinal cord injuries in the steering wheel. So it's not just about involving people in their decision making, which is an innovative, believe it or not, but also is that all the actors in these services are working in silos and they are not communicating with each other. And that's where a lot of information gets lost, and a lot of the care gets lost in translation or falls through the cracks of the system.
And the physiotherapist said in this regard that I often wonder what the impact is once people transition from inpatient to community, because I can only imagine this is a massive transition. There has to be some mental health implication of that, but I don't know what it is, because I don't see people after that.
And as you can see, this is a physiotherapist from a specialized center, right, in a metropolitan area. So it's for me, this is very powerful. It's telling us not only that it's only the person, but it's only the provider who thinks, I would like to know more what is happening with my patients after they leave, right? And that's something that was really, really powerful. So let's move to the next one of the MAX Access acronym, which is education. So there is a clear need to foster learning about the specifics of spinal cord injury for patients, family members, and service providers. This is important to mention, that what we're talking about foster learning is that all the people involved, specialists, not specialists, patients, family members, all of them, that's what we're referring here. We need to learn more about SCI at the different stages of life.
The participants with SCI said that I know that it's complicated and it's a biological thing, but the goal should be that the patient understand what's going on in their body. There should be someone who has the time to explain those things, or just basically understand the process of just living in the hospital and stuff like that.
Finally, let's go to the last part of the acronym, which is the social support. So this theme tells us clearly about the need to provide continuous support from family, friends, peers, colleagues at work, and community organizations in order to ensure that the person surpasses all the biopsychosocial barriers when transitioning to community. These barriers are so wide and so so different according to each individual that's why this cannot be a one discipline or a one service or one organization task. This requires the effective organization and collaboration among a lot of actors here, as you can see, family, peers, colleagues, etc.
And another participant with SEI said that you often don't know that you need to know this until you are in the community. And then all of a sudden you realize, wow, I need to get some more understanding about this situation.
So as you can see, all of these are the results that qualitative research can give you.
And concluding, to improve the transition in care from inpatient to community for people with spinal cord injury in Slave Lake and Lethbridge, it is essential to consider multi-sectoral service integration and standardization that allows continuity of care. And by multi-sectoral, we mean to involving people starting from healthcare providers to community organizations, to individuals involved in the employment services for people after spinal cord injuries, and everyone involved in the care. Next is transversal education for patients, family members, service providers on the unique aspects of SCI. And as for this specifically, it points towards a dynamic process of knowledge sharing between the specialized centers in the metropolitan areas and the rural areas, because the people and care providers in the specialized centers need to understand and educate themselves as of what's going on in the rural areas once they transition people from their metropolitan centers. And for the people and care providers in the rural areas, they need to educate themselves about the SCI specialized care. And finally, reinforcing social support through peers, community organizations, and public and private funding.
Thank you, Rija. So going back to the reflections of the use of qualitative research. So as you can see from the results, these are the types of results that you have, and you just need to be more clear about this. So we can bring the results to different levels. At this moment, they are really close to the data. They are descriptive. They're describing the phenomenon, but they are also giving us direction on how to move. But if you want to move it further, and that's what we're doing right now with another piece of the analysis that we're doing and more in depth, you can even come out with theories about how this works. And that's what we're working right now also in Concentric, is like, let's build what are the assumptions and what are the axioms that actually explain good transitions in health in care in this population. But so far with the results that we have, as you can see, doing qualitative research, we can access to this subjective and lived experience, right? For in this case of disability, and also not only that, but the interactions between person, environment, and illness. So sometimes this is hard to do. We can model that quantitatively beautifully with numbers, and we also can understand about these interactions, but the thing is that we will have a limit there because we need also to understand the meanings of those interactions. And of course, numbers cannot give us that completely. So as you can see, a qualitative approach can allow us to understand and explain social issues in health as this one, right? And also healthcare delivery, as we are demonstrating here, but it's through non-numerical but rich data. So I told you for qualitative, as I repeat myself, for qualitative, the data are the stories and the accounts of people. And sometimes it's really hard to put them together, put them to communicate with each other, and then get some interpretations that produce some ideas that maybe we can create hypotheses that then we can test using quantitative research. So you see how qualitative research is part of the whole process of even getting the right questions for quantitative research. So this is a good example of that. The other one is that, and this is very interesting, knowledge generated is more accessible than complex statistics. So some people will say, well, no, like healthcare administrators and all these fancy decision makers we have in the world, of course they understand complex statistics. Considering that most of them are politicians, they do not. They pretend to do so, but to be honest, they do not. And just think about a situation where you have seen a politician making a decision based on a story, an impactful story, not based on numbers, not based on importance in terms of frequencies, etc., but just by the impact of the story. Rija and I were discussing, we were chatting about this the other day, the example of spinal cord injury in the spinal cord injury world, the example of Christopher Reeves, right? Our Superman. It's so common to hear in this when someone talks about spinal cord injury, that to hear the example of what killed Superman, right? Sorry, there is no interaction here, but what killed Superman? Well, and they say, well, it was a pressure injury, right? Or a wound, because as you know, Christopher Reeve suffered a spinal cord injury. So that narrative, that story was so powerful that visualized the issue of spinal cord injury in the world. When spinal cord injuries have been happening throughout the history of mankind, especially after the big wars, right? Of course, it's not that people were oblivious about that, but it took a famous person to get it, to start visualizing it and giving it more importance. So that's an example of how stories and knowledge generated qualitatively, it's also very useful to bring across messages. And usually we can combine numbers to, like our quantitative research, with these stories, so we can give context to those numbers, and that's what makes our message more powerful. So we wanted to provide enough time, so we have around 20 minutes to have discussion and to answer to your questions. But we want to acknowledge all the institutions that are participating in Concentric and that are making this project possible. And of course, our big team of Concentric, we have over 30 people working now, and of course, Lei for providing a lot of the content and helping us with this. Well, I use a lot of your previous material, Lei, to kind of put together this presentation as well. So I acknowledge you as well. So that's it. Let me just stop sharing and let's open it up for conversation.
Thank you very much, Beto and Rija. It's really very, very interesting to get this exposure to how you're doing your work and the results that you're coming up with. And I think you're absolutely correct. This is the qualitative component probably needs to be going hand in hand with the quantitative component for any study that involves human factors and human needs. So thank you for doing this. We really appreciate it. I'm going to get started with some questions while people start sending us questions in the chat. One is this may sound like a quantitative question, but did the experiences that you were able to to discuss with people and for people to share with you, were these experiences different between genders, between age, since injury? So for example, people who've had their injury 20 years ago or more than 20 years ago, were their experiences and transitions different from the experiences of people who've had their injury less than 5 years ago, keeping in mind that things have changed over the the past 15, 20 years? And did you see those gender / time since injury differences?
So yeah, that's a great question. Yeah, I know where you're going, what you're thinking. This is quantitative question. Yeah, because in order to answer you with the data, yeah, how the correlation was. We don't have the numbers to do that. Yeah. However, what we do have was the narratives, and when we're doing these comparisons, we always go to see the context of who the person is. So definitely there are changes, there are differences in terms of gender, no question. Actually, to the point that now we're trying to collaborate, extend our collaboration with social scientists who have a good understanding and framework to address gender in these types of studies, so they can go through the narratives and tell us exactly. But just without that expertise, I can tell you, yes, the gender issues were quite marked in terms of the perception of the healthcare system mostly, and also the perception of the needs of what can I tell this? The needs to build those networks of peers or not. So it seems that men seem to be a little bit more kind of outgoing and saying, okay, yes, I'm here, I'm out there, I'm okay being out there and try to build those networks. As women are a little bit more reserved. The management, that's very interesting, but this is outside of the transition to community, but it affects it. Apparently the spinal cord injury world is a men's world, because usually it was supposed, like for traumatic spinal cord injury, there were more men than women, right? So we're finding that even though in our purposive sampling, we had a good balance of men and women, we found some subtle changes in the narrative in terms of the service, the types of services that are available out there do not necessarily accommodate for the needs of women, which is quite interesting. So we will continue, that's one of our plans, to continue a gender-based analysis to see how is this so. But yes, I can tell you that. As for the time since injury, yes, that's a good one. I do not, to be honest, I do not recall anything related, but that's a very good point, related to what you're saying, the history and the technology available equipment. Nobody touched on that very specifically. However, what I can tell you in terms of the differences in terms of length of time since injury is that the people who were in kind of like further away in from their injury, it was more common for them to have achieved this stage in their lives in which they say, okay, I know my body limits now, and I can move on and I can live, right? As for the ones who are earlier in the journey, it's a little, they are still struggling a lot with their identities, with this life-changing event. So that for sure it's in there. That's an important thing. We need to make a note and get a deep dive in the data to see if the piece that you're saying here, the differences over technology, medical management, community services available was in there. I don't know, Rija, did you remember reading anything like this?
No, yeah, specifically we haven't had like something striking thing in that regard, but definitely I would like to go back and see.
Yeah. That's very interesting, and I should acknowledge Gwen for that question. I think she hit enter just as I was asking my question. So great minds were thinking alike. But it would be interesting to know whether the 20-year span in changes in care, delivery, in technology, and so on and so forth, whether those experiences were reflective of that change. Or maybe not, and if not, it'll be interesting to know why not. Yeah. So, question from Martin. Thanks, Gwen. Okay, so question from Martin. Are there any concerns about how systematic reviews and journal impact factors rate qualitative research evidence like this? I realize this is very insensitive to the perspective of people living with spinal cord injury, who are likely very supportive of their participation in research prioritization and methods. So what is the scientific world doing? Is it helping? Is it hindering in this kind of research that will have a direct impact on the lives of people with spinal cord injury?
Rija, you want to answer that in terms of what you know, because we're working on the meta-ethnography thing, so maybe you can answer that piece. Yeah.
So I think there has been a growing acceptance of the qualitative research, specifically because because of the fact that qualitative research has come up with more concrete methodologies and methods. But yes, still there is that tug of war sort of thing going on. That quantitative evidence is considered a bit over the qualitative research. But there has been an increased acceptance of what's called the mixed method research, the research that incorporates qualitative and quantitative research in a meaningful way. As for the qualitative research, standalone on its own, there is some resistance, but it is still a step ahead that there is an increased acceptance of mixed method research where the qualitative results do inform quantitative research or vice versa. And I would like better to add on indefinitely.
No, that I agree with you. Like that whole new world in research methods that is called mixed methods. It's I think it's the future for rehab, and we are in a good position here at the UFA because there is a good, strong group that is interested in research. Sorry, in mixed methods research, and also, as you know, the Faculty of Nursing at the UFA is one of the best. Like, it's one of the pioneers of of qualitative research in health. So it's very, very important to acknowledge that that is the future. Don't know, like you can see that in conferences as more and more frequent, this type of research. But I agree, there is still a lot of misunderstanding. Hence, that's why Rija and I took the opportunity to say, I know that this audience is quite varied, but it like Just the Smart Network has a majority of quantitative researchers. So we wanted to bring it up we wanted to focus not only on the concentric, but we also on the reflections of qualitative research, because there are still a lot of misunderstanding and a lot of unclarity what is qualitative research. And of course, if you don't know what it is, you wouldn't know when it's appropriate to use it in your own research questions, right? So yeah, definitely. And now if we're moving toward transdisciplinary work, qualitative research will need to go. And Martin, yes, there is there are, as we have checklists to enhance and maintain the rigor or the scientific rigor of quantitative research. For example, in systematic reviews, we do have the equivalent for qualitative research. So it's very, very advanced now in those areas. So that's a great reflection.
Thank you for that. Michelle has a question. He asks, our current government is focused on reducing costs of healthcare. What arguments can you use to spend more giving better care in rural areas? And I'd like to also link to that aspects of health economics that everyone wants to do right now, and how what you're doing could address what the government is focused on, and their and aspects of qualitative care that go into health economics that would provide better care in rural and indigenous areas.
Yeah, that's a fantastic reflection here. And for this, I will have to rely on what we're doing in Concentric, right? Because that's the next step. And we are in this step right now in the second stage. And it's very interesting because what you're saying there is really true. However, one of the reflections that we have had, and Rija has been part of this, is we believe that in Alberta, at least right now, what we know is that there are a lot of services out there. There are a lot of things that already exist. That means we're not asking anyone to put more money on it. But what we realize is that the connection of these services as a system is lacking. There is no integration. So for those of you who like these information theories, there is no integration of information among all of these services. So that's why they are not doing the best job that they can do, because they are not synergizing with the other services around. So we feel positive about that, because it's not that we're from zero. I can bring you a comparison with another project I do in Mexico in a Mayan community. In there is nothing. Like we did all of this, a similar thing like in this one, we couldn't find a thing. Of course, we found some people there that are interested, organization-wise, very, very few stuff. So in that case, we needed to create something from scratch. And when you do that, you need to invest some money. In this one, I'm not saying that we're going to solve everything, but at least we could have a first step. And if that first step involves less invest of money, but more connection among what is available, then we can move on to the next step of maybe, yes, we will need an investment, but that investment will be better thought of. Yeah. So I don't know, Rija, do you want to add anything to that?
I just wanted to add one. It's a very specific example or a very specific thing that we are touching up on Concentric, and that's the longer wait times for people to get into rehab at Glenrose, specifically here in Edmonton. So and the reason for that is people stay in the inpatient rehab until they have transitional housing available or until their houses are modified for to accommodate for their injury, having ramps and just the basic stuff. And because those things take a lot of time, so those people stay in inpatient rehab until their houses are ready, because we don't have that transitional component of transitional housing. And this not only leads to increased wait time for other people who had newer spinal cord injuries, it also leads to increased healthcare costs to our healthcare system.
That's such a good point, Ria. Yeah, we have evidence on that now, and it's part of the narratives. And yeah, so we're that's one example in which, yes, money will be needed. But if I like that comment here from Michelle that says, yeah, the UCP depends on rural voters. So the stories, that's what we bring, the numbers to the stories and say, yeah, look, it's not only that you're going to change people's lives with the stories, but also money-wise, as Rija mentioned, it is cost-effective to spend more, like to provide the transitional care that people need instead of waiting in inpatient rehab, which is thousands of dollars per day, right?
So related to that, do you think, Martin asks, do you think to create equitable access, rural care needs compensatory or redistribution of resources? So that's kind of related to what you were just saying. Or is it redistribution?
Or compensation?
Compensation, yeah.
Such a great question. I think that's one of the challenges we have in right now at the Concentric. We will have to decide on this. My personal opinion, and then I will let you give yours, Rija, is it's both. For a perfect world, it's both. We need compensation because, yeah, there are things that are still missing. For example, the one for accommodation in employment and to support people to maintain a successful employment. Yeah, there is no way around it, right? Like there are still missing some figures in there that require some investment so we can do it. But at the same time, as I told you, we're not from zero here. We don't need to create things from scratch because there are a lot of people out there. It's just a matter of organizing them. So that will be the redistribution piece. But yeah, Rija, what do you think?
And at this time, our understanding is that there are a lot of pieces out there that need to be connected, and that's our starting point. And after that, we'll definitely look into other missing pieces in the system.
Yeah. So there's a question from Hema that I find very interesting as well. So Hema says, basically saying, you're looking at transitions of care in care. What about transitions in employment, right, for people living with spinal cord injury? So she says, I can see that the meaningful employment transitions are easier in urban areas compared to rural or remote areas. Similarly, housing assistance can be a challenge in remote areas and has been ongoing challenge in metropolitan areas as well. So are you looking at these aspects as well? So how the transitions in care and transition to community and full integration community, is that also looking into transitions in employment?
Yes, we are. The results that we presented today, remember, it was just a very specific point on time in the journey, from inpatient care to community. That means to the house, right? To the home. That was the period of time. But our data, our overall data, includes what happened since the injury, and includes what is happening after they go home, and then they are talking about their employment, their life satisfaction, all of that. So we do have that data, and that is part of what we're analyzing right now. We didn't present that because to move forward the work of implementing stuff, we had to say to the limit, this is what we're interested in at the moment, but now we are analyzing the other data. Yes, this is important. They are very, like, as you imagine, Hema, yes, you're right. There are a lot of issues with housing, and that is in Edmonton and in these areas, because we have some providers, as you know, from metropolitan areas telling us that thing. And then in terms of the employment, such a good question. And I will let Rija to answer, because Rija did actually a systematic review for qualitative research on return to work. And Rija, what do you think? What are we doing here in terms of what you know?
So specifically for yes, I started off by doing a systematic review on return to employment after spinal cord injuries, and I was amazed to see how spinal cord injury, how just employment can affect so many perspectives of life, starting from individuals to social and mental health aspects of people. And I did bring it up to our CONCENTRIC steering committee, but at this point, this is out of, I won't say out of focus, but this is out of the limits or boundaries that we have designed for this. And definitely I was really surprised with the results. I went in and I wasn't hoping to find as much literature, but we did find a lot of literature on that. And we ended up dividing it into a qualitative component of systematic review and a quantitative component. So at this time, they're both being polished and ready to get submitted to a journal for publication.
Yeah, it was amazing, the amount of evidence. And what we can tell you, just to finish up that answer, is that there is evidence at the level of the randomized control trial, the experiment in clinical research, that a good vocational rehab that is integrated with the whole rehab team and that sustains, remember that continuity of care, that sustains the services, not just to get someone to find a good job and a satisfactory job, but also to maintain it. It's doable and it's effective. So we have evidence now to prove that. So now the challenge will be, how can we implement that in our province? And there used to be part of going back to Wen's point of the history, there was some of the people we interviewed with old injuries, they told us that in Alberta, there used to be a vocational rehab program and they shut it off. So it's telling me that Alberta was kind of very progressive because they had stuff that nobody else had, but then they shut it off. So it's and now the evidence is supporting the existence of such services, right? So it's interesting sometimes how things work.
Beto and Rija, I have several other questions over here, but time has flown by and we are at 1 p.m. already. So do you guys mind if we send you questions and maybe you'll be able to answer and we can share them with the participants?
Of course.
Wonderful. So thank you so much for this enlightening talk. Very much enjoyed it, and thank you for sharing it with so many people from many different areas and disciplines. So I think they will all agree with me that you've reached them quite nicely. So thank you very much for this talk, and have a wonderful weekend, everyone.